and then we'll get going here in just a moment.
So I don't need to push on anything here. You're the leader.
I'm the leader. You just have to advance slides and be very entertaining.
As it says here, this meeting is being recorded. Continue. You're taking care of that.
I'm taking care of all that. So just don't hit the stop record button. I'll take care of that at the end. And it was funny. I was with Dr. Henning, I think it was, and he clicked the start webinar button about 25 minutes early.
Oh no!
But it's one of those buttons that just looks like it should be clicked, and he's like, "Oh no, I clicked the button. Oh no!" So we stopped it and had to like reboot the whole thing. So it was pretty funny. So we have some attendees starting to show up here too. Again, I said before offline we were kind of talking, and the attendees are going to be split probably 60-40 medical practitioners to potential clients or former clients or current clients of Dr. Robert's or ours. So
any coaches?
There'll be 3 coaches
Okay.
that I recognize. There may
Okay.
Anyone with children is a coach, probably too.
This is so true.
So I'll start just by doing kind of a long introduction for you. So many people know this. I've mentioned Dr. Robert on podcasts, and we've shared articles. We've had guest blogs. We've done all kinds of things together. We first met in 2002. Correct me if I'm wrong. 2002 at Redmond PT. You had just moved to the Pacific Northwest. I had a clinic that was about a year old, 9 months old at that time, with my old partner Ken Crinklaw, who's a great guy and still manages and owns Premier Physical Therapy in Redmond, with another good friend Clyde Arias. So you'd come over to meet the team, and we were really impressed that we would have not only a second sports medicine doctor in Redmond, which with your Dr. Adams being one of the first ones, but also a female sports medicine doctor, which I thought was just fantastic, because we have so many female athletes that were, I think, kind of wanting that kind of influence and wanting that kind of perspective. The female triad, whether it be just understanding women's sports, and there's no one that understands it better than you. Dr. Robert, her resume is in the show notes and in the links that we've sent out, but it's like the who's who of resume that you would dream of as a young medical practitioner. So she has worked with the Canadian Olympic team, track and field team, numerous years in numerous Olympics and trials. Worked with the Canadian women's national team for soccer, has worked with Cirque du Soleil, has authored articles, has done research, and owns her own business, and has managing 2 practices now, both a sports medicine practice and also a regenerative medicine clinic called Spark Lane. So there's just an amazing role model for so many young aspiring physicians, but also so many female as well. So I was mentioning offline too that my niece will be attending this. This is maybe this will be the seminal moment for her while she decides if she goes into sports medicine, if you have a strong enough impression on her, or if I carry her into physical therapy world. So we'll see what happens there. But without further ado, I'd like to introduce you, and then basically, if people, just my quick housekeeping note, if people have questions, you can click on the questions button. I'll be tabulating those for Dr. Robert. We'll be doing a little bit of a Q&A at the very end. If something's super pertinent to a particular slide, then I may interrupt her, but otherwise we're just going to kind of let her present and not be interrupted. But without further ado, the floor is yours, but thank you so much for coming, and we really appreciate you being here.
Thanks, Ben. So it's my pleasure to talk to you today about soccer injuries. Soccer is one of my favorite sports. I was always amazed to see how fit those athletes can be. It's one of the best ways to get a good cardiovascular health, and you get new skills, you get friends to play with. So I really like watching soccer and treating soccer players. And unfortunately, with any physical activity, there are some injuries that are related to soccer, and we're going to try to go over some of the more frequent injuries with soccer. My main message to you is that there's a way to prevent most of them, and we'll talk about that along this presentation. I won't be able to go in detail with the treatment, but please feel free with any questions you have, or contact me later, because it would be a 4 hours presentation if I was going through all those 4 injuries and going from A to Z. but please feel free to contact me later if you need to. So let's go ahead and so we'll talk about the most frequent injuries, how to prevent them, treat them, when is it safe to go back to play, and I also want to say a few words on new modalities or treatments that I'm using for musculoskeletal injuries, especially soft tissue. So we'll talk a little bit about ankle sprain, ACL tear, groin pain, stress fracture of the lower back. So the ankle sprain is by far the most common injury in soccer. It's the most frequent one. And it's interesting, we were chatting with Ben before, some people will think that, oh, it's mainly happening when you go on an uneven surface, if you practice any physical activity, but in soccer, there's a more frequent mechanism even, it's when you get hit by another soccer player, and you see that on the picture here on the slide. So that's a very frequent mechanism. So even if you have good footing, good technique, that can still happen to you. That being said, you can still have a the non-contact ankle sprain is still the most frequent injury. And it's usually happening in an inversion mechanism. So for those of you who are familiar with it, the ankle goes out, the foot goes in, like expressed on the slide here. The eversion mechanism is more rare, the deltoid ligament being way a structure that is way tighter, stronger. So we usually don't see it by itself. It's usually almost always connected to a fracture or a syndesmosis injury. Always be aware, an ankle sprain is not always a simple thing. Always be aware of fracture, growth plates, injuries, syndesmosis, lesion, and cuboid dysfunction. Make sure you assess the ankle and the foot every time you see an ankle sprain, even if it looks like it's a simple one. So here's a picture of all the ligaments in the ankle and the foot. The most often structure that is having the issue with when you get an ankle sprain is the ATFL, the number 1 on your slide here, and most often associated with the 2 other ligaments of the lateral ligament complex. Be aware of the syndesmosis injury that can happen. We call that the eye ankle injury that will take way longer to heal. And always make sure that your cuboid doesn't get a dysfunction. It's also very common with ankle sprain. So very often people don't know, should I go to ER? Should I get an X-ray? So there have been an extensive studies done in Canada a long time ago, where radiologists review hundreds and thousands of cases to decide when it would be mandatory to do an X-ray. So the criteria are the following. If the patient cannot walk on it after the ankle sprain, or if you have pain at one of those 4 locations, namely lateral malleolus, medial malleolus, 5th metatarsal bone, and navicular. So if you get pain there, you send them for an X-ray. If the pain is only located at the lateral ligament complex or the syndesmosis, and there's absolutely no pain at those 4 locations, and the patient is able to do some weight bearing afterwards, they don't need an X-ray. So that's the Ottawa rules. So as I told you at the beginning, I want to talk about how can we prevent all those injuries. So every time I'll talk about risk factors, I'll talk about how we can prevent them. So first one is alignment. So people who are having too much supination are at risk. And on the contrary, opposite, too much overpronation put them at risk too, because that makes an unstable foot and ankle. So prevention, then it's important to have orthotics. Orthotics can work in soccer shoes, Ben can make them. So people sometimes are thinking, oh no, that won't work for me because soccer shoes, it's tight and it's a low shoe, but they are always able to make some corrections there. Other risk factors, the strength, range of motion, proprioception, we can work on those with some prevention exercises. So for coaches there or soccer players, you should have in your routine, even if you never had an ankle sprain, you should have in your routine some exercises to take care of your ankle. Make sure you have a good motion, strength, and proprioception. The major risk factor for an ankle sprain is if you had an ankle sprain before. So this increases your risk of ankle sprain by 5 to 10 times. So it's very important to protect the ankle once you had one, to protect the ankle with brace or taping in the future. Actually, I was working at FIFA for the Female World Cup in 2011, and their recommendation is that you should tape for up to a year. That's what FIFA recommends. So now that's not what everyone is doing, but it's good to keep in mind that if you had an ankle sprain, your chances to have another one in the next year is 5 to 10 times. Treatment, basic treatment very quickly. So conservative most of the time, price as you know it. Neuromuscular training is extremely important. I send all my ankle sprain to PT, even if it's a grade 1. It is important to get them back with a good proprioception before they return to play. So it's probably one of the injuries that is not treated well in sports medicine. I've seen so many people telling me, oh yes, I had an ankle sprain when I was a kid. Oh, I had so many of them. What did you do to treat them? Nothing. So whenever someone has an ankle sprain, they should go see a PT and do the proper rehab, because that can prevent the risk of re-injury for future, and that can also prevent damage to the ankle. We know that if you have multiple ankle sprains, eventually you will probably develop osteoarthritis in your ankle. So it's important to treat it right away. Taping and brace, we already talked about that. So it's important to tape and brace at least until you get the proper stability and you give the time to the ligaments to heal. Okay. So that's for ankle sprains. Now let's talk about ACL tears. So for those of you who are not familiar, the ACL is probably, to my sense, the most important ligament in the knee. It's important because it gives the stability to the knee. So I know you had a webinar not long ago with extensive and very good care recently. So I'm not going to go in detail about the care, the surgery, etc. It's been done already. But I want to talk about the risk factors and what we can do to help to prevent those injuries. So female are more at risk than male to get ACL tears, especially the non-contact one. So they are 2 to 10 times more at risk. What makes you at risk to have an ACL tear? A small intercondylar notch. So this space here, if you were born with a very small notch, you're more at risk. So that might explain why female are more at risk. Also, I've seen male with a small notch, and that puts them at more risk for ACL. Muscle imbalance, especially weak hamstrings. Hyperlaxity, people with recurvatum of the knee are more at risk. When there's a high index of friction, so the shoes, the surface, the weather, they all have an influence of the friction index. And the higher the friction, the higher the chances to get an ACL tear. Very important factor, the way you're landing when you are running and jumping. Other risk factor, family history, probably because of the narrow intercondylar notch. And sometimes there's also some genetic risk of injuries to ligaments. By the way, parenthesis, there's a new thing that we can do when people have done either 23andMe or Ancestry. There's a program that I can run to assess your risk for vitamin deficiency, what you're good at for physical activity, but also it's giving us some indication if you have the genes that are putting you at risk for ligament injuries, especially the Achilles. So that's interesting because there are supplements that you can take that can help you for that. End of parenthesis. And finally, a prior reconstruction. So obviously, if you torn your ACL once, you're more at risk to tear it again. If we look at the mechanism of the injury for a non-contact ACL tear, non-contact means that you tear your ACL without nobody hitting you or or falling or anything like that. So deceleration with a change in foot position, there's a typo here. It's in closed chain reaction. So we call that the valgus loading. The other risk is landing from a jump with a lack of hip or knee flexion. So if you're close to hyperextension in your hip or your knee, you're more at risk to tear your ACL. So I'm going to go over again. I won't go in super detail here. I want you to read those 2 slides. But for each mechanism, there are things that you can do to prevent the injury. So when you have lack of knee flexion, lack of hip flexion when you are landing, there are things that you can work on. I go on the next slide. If you land with your knee in a valgum position, if you have issues with your balance, if you have issues with lack of skills like beginners in soccer, there are drills, there are exercises that you can do to prevent the ACL injury. So why is it so important? As I said, 70% of the ACL are non-contact. Obviously, it's hard to prevent the one that are, if you're hit by another player, it puts your knee in valgum position and your foot is stuck there and you tear your ACL. It's hard to prevent those, but remember that 70 of them are non-contact. So there's a lot of ACL that we can prevent here. There are some programs that you can load if you Google them. The PEP that was started here in the US and the 11 plus that's coming from FIFA. And there's probably some other programs too, but with those 2 programs, they did some studies and they were able to show how much it was helping to decrease the rate of ACL tears over a year, not only in professional soccer player, but in amateur as well. Let's talk about groin pain. This is also a common injury with soccer players. The most frequent one is the adductor sprains. And the differential diagnosis here, you have a list of possible issues that you have. But first thing, most of the time is an adductor strain, and then there's other possibilities. We'll go over that in a second. I don't want to take too much time there. I'll be happy to discuss them with you more, if you think you could have that, or if you think one of your patients has it, I'll be happy to talk about it. I'll talk a little bit more with the sports hernia in a minute. So adductor strain, mainly happening because, well, contact injury possible, but also non-contact with kicking. It can be an overuse injury because of the nature of the sport. Remember that the adductors are attaching to the pubic branches. So it can also cause an avulsion of the bone. So it can be damage to the tendon, tear to the tendon, a muscle strain, and it can be a bone avulsion. And it can be also issues with the bone. I'll come back to that later. Rectus abdominis tear, so it's your abdominal muscle that can tear. It's usually close to the pubic branch, but higher. It's a different diagnosis than the sports hernia. We'll come back in a minute. And it's usually happening in the muscle part or at the junction of the muscle and the tendon, so myotendinous junction. Those are usually healing pretty well, but you need to diagnose them properly and to give them the time to heal. So osteitis pubis, so the pubic symphysis is really at risk of injuries with the soccer player. Why? Because our adductors are attaching on the pubic rami, and they can pull one side or the other, creating some shearing forces. And eventually you can develop some inflammation in that joint, some osteoarthritis also. And so that can be extremely painful. It is treatable. We can do some PRP injection when it doesn't go away, especially if there's some osteoarthritis. But the most important thing in this case is to make sure that we get back a proper pelvis stability. So SI joint has to be symmetrical, moving well, because it's a 3-joint. The pelvis has 3 joints, the 2 SI joints and the pubic symphysis. So you need to make sure that the pelvis is moving well and is stable. And you need to make sure that you have a good balance, good flexibility, good strength in your adductors in order to prevent this from being painful. So the sports hernia is very interesting. It's not a common injury, but I see it mainly with soccer players, hockey players. So it's an injury that is affecting the posterior wall of the inguinal canal. And it's way higher than the inguinal herniation that can happen in this area. So it's higher just above the pubic bone, and it's going to present as groin pain, and it's not easy to diagnose because sometimes you do all your maneuver to rule out the adductors, the osteitis pubic, everything is negative. So the way to make a proper diagnosis of that, my best way is to have my patient standing and palpate the area of concern and asking them to do a Valsalva maneuver to cup. And if I can feel the bulging and the pain there, especially if it's on one side and you don't have anything on the other side, you're pretty much certain that is a sports hernia. To confirm, I will send them for an MRI, but an MRI lying down probably won't give you any good, I mean, for some of them, it's going to be positive, but for many of them, it doesn't confirm the diagnosis. So what I ask to confirm that is an ultrasound sending with a Valsalva maneuver. So you can do it yourself if you have access to an ultrasound, or you can send them to your favorite radiologist, asking them to do the exam, standing and performing a Valsalva maneuver, and you can get the diagnosis this way. Previously, they were repairing this injury just the way they would do for an inguinal hernia using mesh, which I don't like in an athlete, an active person, because you have foreign body, they often get scar tissue, they often get pain. So there's a new technique that was developed by actually a Canadian who is now in Germany, close to Munich. I had the chance to visit her. And she taught this technique to many providers in the States. So I have names of those providers who do this technique. Unfortunately, to my knowledge, there's no one in Seattle, unless you know someone now, Ben, but I've been sending them to someone I like in California. Anyways, the technique is to try to rebuild the posterior wall by doing a fold of the posterior wall and stitching it. And it's extremely effective, and the return to play is way faster than if you put a mesh there.
Well, I think to your point too, I think the recent issues with mesh and some of the recalls of mesh and some of the long time rejection and inflammation from mesh is something to be noteworthy there too.
Yeah, and not only that, the rehab is so much longer with a mesh. With this technique, Dr. Musawek in Munich, she returns our pro soccer player within 2 weeks. So yeah, so I've sent one patient there. He was a pro player and he went there to get his surgery. Anyways, so to prevent the groin pain injuries, pelvic stability, as I said before, is the most important. Be also aware that your patients can go back to play with compressive shorts. That is also very helpful, not that much to prevent, but for good proprioception and for comfort and also a sense of security. I really like those for that kind of injury. But you need to make sure that you took care of the injury properly before you return them. Spondylolysis or stress fracture of the lower back. It's not super common, but I always like to talk about it because it's so important to diagnose it right at the beginning, because it can save a back for the rest of their life. So normally it's definition. The stress fracture is usually happening at the pars interarticularis, which is a part of the vertebrae in the back. It can be one side or both sides, and it's most often at the L5 level. And for me, it's the first thing I want to rule out when I see a young teenager or adult, soccer player or not, complaining of low back pain. So it's very common with people who are doing a lot of back extension, like when you're kicking a ball in soccer. I see that with gymnasts, with ballerina, hurlers. I see that a lot. So when you have a young teenager, young adult with back pain that doesn't go away, keep in mind you want to rule it out, because if you can treat it at the onset, you can heal it completely. If you don't diagnose it, they will stay with a stress fracture on one side. They can get a stress fracture on the other side. Then the vertebrae can start to slide. You have a spondylolisthesis that can require surgery because it compresses the nerve. So it's serious, and there's a treatment. So look for it. And if you think it could be it, then go ahead and refer them to someone who can do the images to confirm it. So talking about images, plain X-ray usually won't show it. When it will, we need an oblique view. And if you look at this image here, typically it's a break in the neck of the little Scottish dog. If you can identify the Scottish dog here, it's a break in the neck of the Scottish dog. Usually to see it on an X-ray, the fracture has been there for a while, and we like to diagnose them even before we see it. So if it doesn't show anything on the X-ray, you need to move on, and you have a high suspicion, you need to move on and do more images. The bone scan is a good way to diagnose, but it's non-specific. So you see here that there's an uptake of the technicium here. That's telling us something's going on, but it could be also infection, tumor. It's not specific for a stress fracture. Obviously, with a young and healthy player, it's most likely a stress fracture, but the exam of choice is the MRI, because then you have the specificity, you know that is a stress fracture, and it also gives you a little idea of the age of the fracture. If there's bone marrow edema, it's more recent. If there's no bone reaction, that's telling us that maybe it's an old one, and you could still try to do the treatment and heal them, even if it's subacute or chronic, but the chances of healing are not as good.
I can interrupt for just a second too. I
Yeah.
think just for the medical practitioners and the PTs, particularly on the webinar, is that Dr. Robert is kind of my go-to over the years, the last 20 years in this scenario. And this could be a gymnast, it could be soccer, like we mentioned. It could also be CrossFit people working on pull-ups and also loading under extension. So if you have someone who's kind of lingering and you're not sure clinically presentation-wise why they're not healing at the rate that you would expect, then I think a referral to Dr. Robert or somebody you trust is a really great idea. But you've always done a great job conservatively with these folks, so it's a real safe referral. Yeah, and I will return them back to you if it's not a stress fracture, and if it's a stress fracture, we'll heal them and I'll return them back to you because they will need rehab. So risk factors. So it's important to talk about it too, because there are things we can do to prevent those. So the first one, unfortunately, there's nothing we can do. So you got your genes from your parents, you can be born with a small pars, and unfortunately, there's nothing we can do to prevent that. But the other risk factors that are associated to the injury, we can work on them. So overuse with back extension and rotation. So anytime people have back pain, it's important to go through adequate recovery. Core strengthening is important. And then if it doesn't get better, make sure you diagnose it. But also once we've been diagnosing it, treating it, it's going to be important to do the adequate recovery and the core strengthening before you send them back to play. So usually after you heal L5, S1, one side pars fracture, it's not going to happen again. The bone will be even more tougher than it was before. But this patient is still at risk. They can injure the other side, they can injure the level above. So it's important to not only to rehab for their specific injury, but to prevent that from happening in the future at other levels. We had sorry to interrupt you. No, we had to interrupt. This will be kind of right on track with what you're talking about. We had a quick question from Michael, and he said he had a soccer player that had an MRI for spondylolysis and it came back normal, but still has back pain, which they're treating with vitamins and core strengthening. Is there any additional things that maybe you would look at? And maybe you're kind of getting to this in the next slide, but I just want to throw that out there from Michael.
So the MRI is absolutely normal. There's no even bone marrow or stress reactions, because sometimes the radiologist won't say spondylolysis or fracture, but there will be some sign that they could have a pre-stress fracture. So I would look carefully, make sure they're not talking about a little bit of bone marrow at the pars or anything like that. Obviously, you want to, for me, the most important thing is the core. We know it's an injury that is happening with a lot of hyperextension and rotation. So if you can rehab the core, rehab not only the deep transverse abdominal muscle, but the obliques, the way they are moving with their trunk versus their pelvis is extremely important. Another important thing is that very often we see lumbar issues, but the reason why it's happening is either pelvis instability or a very tight T-spine that is not moving. So you want to work on that in the rehab too, when you're working with people with chronic low back pain. Does it answer the question? Okay, so the two other risk factors are not only connected to stress fracture of the low back or spondylolysis, but more generally to any kind of stress fracture. That's why I put them here. But nutrition, I've seen a lot of patients with stress fractures in the last years. Actually, since I've moved to Seattle, it's interesting to see how many people with stress fracture are vitamin D deficient. So, and even more with the COVID, people were all working remote, going to school remote, staying inside all the time. So make sure they're not vitamin D deficient. I actually recommend people here to take 2,000 a day, 2,000 international unit a day with K2, and even more if they are more at risk for stress fracture. Adequate calcium and protein intake is very important. The bone is alive. You need to nourish the bone to prevent stress fracture. And we talked a little bit about female athlete triad. So it's a condition that causes amenorrhea, osteoporosis associated to eating disorder. So it's important to educate well, it can happen with male, not the amenorrhea, but risk of stress fracture with eating disorder is also happening with male. So it's important to educate our patients, our kids, that it's important to have adequate calorie intake when you are physically active. And for female, if they lost their periods, it's important to restore them because their estrogen level is low, and that's why they're at risk of stress fracture. There are some estrogen receptors in the bone, and if there's no estrogen, the bone is way weaker and more prone to break. So I just wanted to make sure that we consider that when we're dealing with any patient with stress fracture. When I see them, I'll monitor their vitamin D, I'll do a bone density. Sometimes I even do more specific tests if I see a patient with recurrent stress fractures to see if they had an issue with their calcium metabolism. We want to know why it's happening so that not only you're treating them, but you're preventing this from happening again. So the treatment for a stress fracture as spondylolysis is a brace. I'm very strict. So brace 24/7 for 3 to 4 months. At first they rest, but eventually it's relative rest. After a month, I let them do activities at low risk like jogging, bicycle, but I don't let them play soccer before the 3rd month. If everything is healing fine, they have no pain, they're compliant with their brace, my exam is negative, I will let them play with their brace the 3rd month. And before they remove the brace, I want to make sure that the fracture is healed, and I want to make sure that they won't play without a brace before they do any kind of rehab. So brace 3 to 4 months rehab, and then they can play without a brace if the fracture is healed. We talked about the risk of spondylolisthesis. If you fracture both sides, the vertebrae will slide, compress the nerves, that could lead to surgery. Here's my daughter when she was playing. I miss that time. Okay, so we've talked about one of the four common injuries in soccer. So I just wanted to talk about prevention in general. So when we want to prevent injuries, we need to make sure that the core is strong. We need to do some neuromuscular training to stabilize the joints. I really like eccentric strengthening. So it should always be towards the end of the rehab program that we teach patients how to strengthen with eccentric strengthening, and also in the prevention programs that we discussed before, the PEP and the 11 plus, there's a lot of eccentric strengthening exercises in those programs. Plyometric agility training is also important in the prevention of soccer injuries. I said I would talk a little bit about new treatment. So are we good on time, Ben? Yeah. Okay, so I just wanted to talk about 3 new well, new or not that new, but that you should be aware about soft tissue injury. The first one is shockwave. So extracorporeal shockwave therapy. It's super interesting therapy. It's very effective. So just a brief history. It was discovered in Germany in the 80s, early 80s. And they discovered that this machine, which is producing waves like sound waves, was useful to destroy kidney stones when they were too big to pass naturally. So to avoid surgery, they started to use this modality, shockwave therapy. And their patients were telling them, oh, it's also helping my back pain, how come? And we were able to discover that depending on the way you're using the machine, it can either help to destroy scar tissue, calcification, bone spur, or heal soft tissue injuries. So if your beam is going radial versus focus, the energy you're using, the number of pulses, the probe you're using, the depth of the treatment are all you can set up a protocol depending on what you are healing. So the way it's working, it's really a physical mechanism. So the wave goes in and comes back and meets the next wave, and that causes a kind of implosion, and that is jump-starting the healing process, helping to repair tissue, create new blood vessels, and also re-innervation. So it's very useful in a bunch of conditions. For me, it's extremely effective when I deal with soft tissue injury that is very close to the skin. For example, plantar fasciitis, Achilles tendonitis, patellar tendonitis, tennis elbow, golf elbow, anything that is very close to the skin. It's also helping for periosteitis, non-union fractures, a bunch of conditions. And I invite you, if you have the time, to go on my website. I have a blog there on shockwave and all the indications, but it's very effective and there's no downtime, contrary to the PRP. So for example, I used to do a lot of PRP injections for chronic Achilles tendonitis that wouldn't get better with conservative treatment. And nowadays I barely do any unless there's a major tear in the tendon. Now I use shockwave and it's usually somewhere between 3 to 6 treatments. There's no downtime. That's the good thing. You don't have to put them in a boot. There's no downtime. Once it's healed, you send them back for rehab. And it's usually 3 to 6 visits. Visits are 3 to 7 days apart. So it's a quick healing process. And then patients are able to go back to their rehab and go back to play. The only down aspect of it, or the bad aspect of it, insurance won't pay. So that's very sad. And the machine is extremely expensive. The one we got here is $40K, so we cannot give the treatment for free, but we try to make it affordable for patients. And it's usually, as I said, 3 to 6 treatments, minimum of 3 for sure. And then we add 1 at a time if we need to. For most patients, 3 is enough.
We were actually talking beforehand too, and I think the shockwave therapy, although expensive machine, I think is something that is such a great opportunity versus corticosteroid shots into the plantar fascia. It's been a really great tool. We've worked with patients with shockwave pretty much since you started doing it. A couple other physicians that we work with use it regularly as well. It's great for tennis elbow, great for proximal hamstring, great for plantar fasciitis, so and Achilles. So it's been a really, really, really good tool. So check out her website. You've got great information on there and some blogs as well. So.
Okay, next one is PRP. You're probably familiar with it. I just wanted to say a few words about it. Platelet, fish plasma, platelet. So the platelets are one of the components of the blood. So you have red cells, white cells, platelet in your blood, white cells fighting infection, red cells transporting oxygen. Platelets are very rich in growth factors, so very useful to treat injuries where the blood flow is not good to start with. So we're talking about tendons, we're talking about joints, we're talking about ligaments. They don't have a good blood flow, they don't have platelets. If we bring platelets there, it's going to help to heal the injuries. So now that I use shockwave a lot, I use the platelets for soft tissue mainly when the shockwave is not successful, and it's usually because there's a tear. And even though shockwave can heal small tears if we are persistent, I had a patient who had Achilles tendonitis. After 3, I did an ultrasound. There were some small tears. I said, "You want to do a PRP?" He said, "Oh no, I would rather continue with shockwave because I don't want to be in a boot and have to rest for a month." I said, "Okay, let's continue shockwave." After 6, we rechecked, the tears were gone. So it can work. Shockwave can work for small tears, but if the tear is bigger, I would say it would probably require some PRP injection. So PRP, we have different kits on the market. Make sure you are dealing with a provider that knows his stuff, is using the best kit with the major percentage of platelet. You see the one I'm using is more than 85%. Some kits on the market give only 6% of platelet. They're cheaper, they can get a better margin out of their injection, or they can charge less. But bear with me, if you do it, you'd better do it with a good kit, with a good concentration of platelets. Also, you need to have a provider that knows how to almost personalize the treatment with platelets, depending on what you want to achieve. If you're treating a joint for osteoarthritis, you don't want to create too much inflammation. And so your recipe for the platelets will be with leukocyte poor, so very small amount of white cells. On the contrary, if I'm dealing with a chronic hamstring tear, I want to provoke a certain amount of inflammation to kickstart the healing process. And I will, in that case, use a leukocyte-rich PRP injection. So always important to make sure that your provider is aware that there are different recipes, and you want to make sure that they're going to use the best for your patient. Also, make sure that the injection is done under ultrasound guidance. We are in 2021. It's so important to make sure that you put your needle where you need to put it and inject it. This is not cheap stuff. So you pay for something, you want to make sure you're going to put it where you need it. Just as a parenthesis, they did a study maybe 10 or 15 years ago in Canada, and they were trying to see if the rheumatologists and orthopedic surgeons were accurate in their injection when they were not using ultrasound. And they found out that experimented providers were wrong 30% of the time injecting knees. And knees is an easy joint to inject. And even though they were used to inject it, the rate of success was 70% when they were doing it blindly, compared to 100% when you did under ultrasound. So to me, that was a no-brainer. I got my ultrasound device at that time when I saw that study. The new kid on the block is what we call the super shot. So I don't know if any of you have heard about that. So with the super shot, we are adding exosome to the PRP. So exosomes are small vesicles that we find in the plasma. So once we extract the PRP, the rest of the plasma has inside some small vesicles called exosomes, and they are very rich in growth factors that are slightly different from what we find in the PRP. But also they have what we call mRNA or messenger RNA. So they can give a message to the tissue of our patient to say, hey, you should start healing that. So they talk to the stem cells of the patient. So it's not a stem cell injection, but it can give a message to your patient's stem cells to say, hey, help us here. We need to heal this injury. So previously, the only way to do exosome injection was to buy them, and they were coming from another patient, obviously. It was a long process to get them, and was also not very safe to me. I didn't really like it because you get a product coming from someone else. You don't know if it's totally safe, even if they do all the tests. For all we know, I always tell patients, I'd rather use your own stuff. Just think about the COVID or Zika virus. We didn't know they were there until a few years ago. So if we use substances that are not yours, maybe in a year or two from now, they will discover, oh, there's a virus and you should test your patient because maybe they got this virus from that injection. So I'm not a big fan of using any blood or other products unless absolutely necessary. But now we can isolate the exosome from the own patient plasma. Before that, it would have taken 60 hours of centrifuge machine to be able to do that. But there's a new product called Super Shot. What it is, in fact, is a way to centrifuge the exosome faster with one spin, and then we can add it to the PRP. So I like this new product, especially when I want to achieve results faster. It's a little more powerful than just the PRP. That being said, PRP is still very good. There are some conditions when I'll tell the patient to talk to you about that if you need more detail. Okay, we're doing good on time or getting tight? Return to play. So if you are going to the Olympic Games, or if you are just starting to run or play soccer, the time to heal is the same. God made our body the same. It's all the same. It's 6 to 8 weeks minimum when you want to build up new collagen, when you want this tissue to heal completely. That being said, for certain injuries, some people can go back earlier as long as you protect. So what are the goals before you return a patient to play? The tissue has to be healed. You have to have normal strength, and you have to be able to do some sport-specific training, reproduce what you're doing in your sport, and having absolutely no pain before you can go to practice or to play. Finally, protection is important. I forgot to mention when we were talking about ACL that there's nothing to prove that wearing a knee brace will prevent ACL injuries. So I don't recommend brace to prevent knee injuries, but for ankle, it's been proven that it can prevent injuries, especially if you had a previous ankle sprain. So as a sports medicine physician, my goal is to keep players healthy and injury-free. I like to work as a part of the team, coaches, physical therapists, athletic trainers, nutritionists. We're all there to help the patients to heal of their injuries. And I like those 2 jokes. I thought they're funny for people who like soccer. Thank you.
Thank you for the great presentation. That's good. Amazing content, and there's so many things that I want to ask. Let me throw this portion of my screen up here just to have your information on there, and we'll have the full webinar accessible through the archive, but we'll also have it on our YouTube channel as well. So if you have friends, colleagues, family, coaches that you want to share it with, it's a real easy share. Make sure to like and subscribe, of course. We have links to Dr. Robert's personal page as well, so you can kind of find more about her and all the things that she does, because she's been cutting edge since the day she got to Seattle. So she was always pushing the limits of what was accepted as norms, and then the rest of everyone has kind of caught up to you and now you're on to the next thing. So I think the exomes is kind of the super shot is kind of the next thing that we're going to be seeing really catch fire over the next couple of years. Well, we did have one question from Jordan, who's one of our therapists at the Kirkland office. And he said he might have shown up a little bit late from lunch, but he said, just to reiterate, maybe from your opinion on the gold standard for diagnosing the spondy, what do you feel is the best?
Well, the first thing is the exam. So you want to assess your patient. You want to do some testing and extension. I like to do the one leg extension test, and then I like to have them do the cobra and palpation. If any of these causes any kind of pain, send them for images. I usually order X-ray first because unfortunately with insurances, they won't authorize the MRI if you don't have an X-ray. So X-ray, 99% of the time it's going to be negative, and I move on right away to an MRI. I'll use the bone scan in certain situations, especially if the MRI shows a stress fracture. They're unable to see if it's still, if it's acute or if it's an old one. They don't show any marrow edema. And I want to know if the body is still trying to heal. So if the MRI, I want to know if there's still activity, because it's not fun for a patient to be in a brace, especially for chronic. Sometimes I'll try 6 months of bracing. So I want to make sure that their body is still trying to heal the first, and then I can tell the patient, it's worth to try because your bone is still trying to repair, and it's worth to do the brace for up to 6 months. Does it answer?
No, I think that's a super solid answer. And I think that's what you've seen best practice. And I think that follows the research guidelines that you see year after year.
One thing, once you want to know if it's totally healed, sometimes the MRI will still show a little bit of marrow edema. The bone scan will still show a little bit of activity, and the patient is totally pain-free. So the exam of choice, when they've been in a brace for 3 months and they're pain-free, if you want to know if they're totally healed, is a CT scan. Now, the CT has a lot of radiation, so I never use it as a diagnostic tool. I use it to confirm the healing when I'm sure clinically everything looks fine and the patient wants to know if they're okay to go. And I will order a CT with a very focused area, like a left L5S1. So the radiation is very limited to the area of fracture. So don't use the CT as a diagnostic procedure, but it can be used to confirm the healing.
No, that's a great point. You don't want to be having multiple CTs back to back if you can avoid it. Here's kind of a more general question, and this might be interesting for everyone out there, and that is, what got you into sports medicine and made you choose this as a profession and kind of a part of your life for the last 30 plus years?
So as a young girl, a young teenager, I was extremely active. I did play about anything, you name it. And I knew I wanted to do something connected with physical activity and sports. So when was the time to decide what I would do to go to college, I decided to apply in physical therapy and medicine. And I thought, okay, if I go in medicine, it's going to have to be something connected to sports medicine, which was not something existing in Canada at the time. Actually, I started the chapter of sports medicine in Quebec. I was the first French-Canadian president of the Canadian Association of Sports Medicine. So I was a pioneer in my neck of the wood. That's what I wanted to do from the beginning.
Well, you've never stopped being a pioneer, so that's good, no matter which woods you're in. Maybe talk a little bit about your favorite athletes that you like to see, and maybe if there's a particular athlete over the years that you can think of.
Well, who I like to see, it's going to seem funny, but the big challenge for me is to see someone who wants to be healed for yesterday. They have a competition, they want to go back, they have a game, they are going to Olympics or to a major race. This is a big challenge for me because I want to be on top of what I'm doing with them, and also I want them to heal properly. So I know that they will challenge me. They will want me to do a diagnosis and plan of treatment. I know they will challenge me to continue their activities, and it's important for me to keep them active because I know that they won't want to rest. So important to talk about cross training, what they can't do and what they can do while they are healing. And also to let them know that not only I want to diagnose what's going on and treat it, but I don't want it to happen again. And I'm going to take care of finding the causes so that we can prevent that from happening in the future. So those are my favorite patients. Challenge, I like it.
That's a great answer. And I think it's interesting. Just you and I have had a chance to both work with professional athletes and been fortunate over our careers, but I feel like I'm still as under the same amount of pressure when it's someone that I see at the grocery store every time I go, like when it's your client, you're like, because there's an expectation of like, you want to make sure this person gets better. So I think it's the professional athletes, you're on a huge stage, but sometimes the
I saw a
local.
patient this morning, and she's going to compete in a fencing event in July, and she wants to be ready, and that's a challenge to me. I want her to be ready, and
Right.
I will do my best so that she can compete. And it's not Olympic Games. We're talking about just competition.
Yeah, still goal generated.
Yeah.
Can you talk a little bit about your relationship with Cirque du Soleil? I know they've been traveling out to the Northwest here for close to a decade now, and I think people here just marvel at those athletes. But you've had a chance to get your hands on them.
Yeah, actually, I
talk about
started
that.
to treat them. So Cirque du Soleil, for those who don't know, was born in Montreal, where I'm from. And so I started to treat Cirque du Soleil athletes when I was practicing in Montreal. So we talked a long time ago. And when I moved here, when I found out that they were coming touring here, I got in touch with their head PT, which happens to be the PT I worked with at the Olympic Games in Sydney in 2000. So I just sent him an email. I said, hey, I'm here. If you need me, I'll be happy to help. And it was very nice because they call them artists, but they are athletes. And what we see mainly with them is overuse. So they are touring, they don't have a lot of time to recover. So we see some traumatic injuries, but mainly we deal with overuse, osteoarthritis, even if they're very young. So I used to see some of them coming back year after year, and I would give them their hyaluronic acid injections in their knees. And so it's very challenging also to work with them. There's a lot of overuse injuries. And it's also interesting to watch their bodies, like when you see how much they can, their flexibility level, sometimes it's abnormally flexible, as you know, and that's why they can perform like that. So you still want to keep them injury-free, and it's a fun group to work with.
Yeah, I think it's an underappreciated thing from the standpoint of the amount of shows that they do, where it's almost similar to a Broadway schedule, but with an athletic event. So it's probably one of the most demanding things you'll treat athletes from, I would think. I know you and I collaborated on one back in the early 2000s when they traveled out here, and it was one of the most amazing athletes I've ever seen, just shockingly toned. I know you've seen so many athletes over the years. What is there one that stands out to you as like one of the more impressive specimens in one of the maybe Olympic Games or anything?
Yeah, well, there's one that is really dear to me because I got to know him. I was a coach in track and field, and I got to meet this guy when he was training at the same track that I was training my race walkers. And at the time when he started, he was a long jumper. And this guy became a famous sprinter in Canada, one of the most famous. He was part of the team who won the 4x1 in Atlanta. They won the gold. We 2 Americans. And he also holds the record of the 60 meters indoor. His name is Bruni Suren. But what I've been following him, helping him. I was fortunate to be with him at 2 Olympic Games in Barcelona, in Seoul, as one of the Canadian doctor for the team. And what I liked about him is that even though he was famous, he was talented, he's an amazing athlete, he was also very down to earth, and he's still now to this day, he's still a dear friend of mine, very humble. And, you know, we treat a lot of athletes or not that recreational people. And some of them sometimes will have this personality like a diva, and they have rights to get this and this and that. And it's very nice to see that some professional athletes or some elite athletes don't have this personality, and it's so nice to work with them. So lately I've been seeing another athlete who's connected to the Seahawks, and same thing, I was amazed to see how this guy was so humble and sweet and nice and not demanding. And so it's nice to work with those people.
Yeah, I think when those athletes participate in the practice like a normal patient, and they just treat you like another human being, I think they actually end up getting better treatment than the person that's demanding. So I think at the end of the day. Well, one last question here. So, and we'll let you go. I know you got a busy clinic afternoon seeing patients, but when you're not running your two businesses, when you're not walking your dog, when you're not reading research, what do you do with your half an hour of time left over?
Yeah, you know, Ben, I have a major issue standing still or sitting still. So I'm always active. So that's probably why I understand my patients when they are injured and they want to continue to be active. So I run, I bike, I hike, I ski. I'm not sitting still. So that's for me, it's the best way to recover mentally from the burden of my work. It's the best way to get connected with nature, and it's the best way to get fit and healthy. So I'm moving. When I'm not doing anything, working or reading articles, you'll find me out on the trail.
And hopefully your husband Sam understood that when he married you, that he would now be moving the rest of his life too. So
he's not always moving with me, but he's totally fine when I say we're gonna have a late dinner. I need to go for a bike ride or run. He's totally fine with that.
Awesome. Well, hey, one quick housekeeping note. Our next webinar is July 15th with Dr. Grant Garcia, and he'll be talking about some biologics related to the rotator cuff. He'd be hosted by one of our newer owners in West Seattle, Mark Bumma. And I just wanted to thank Dr. Robert again for coming on. We've been colleagues for forever now, probably one of the longest relationships I have professionally with anyone in the region. So it's really exciting to connect. We had some fun shooting some videos that you may have seen before this webinar, kind of connecting again, kind of post vaccination. So it's kind of fun to be able to see our physician friends in person again. But I really appreciate you doing this and for all the great work, and you know, patients have so much admiration for you, helping them who, like we had talked before, you know, have seen multiple practitioners, have seen PTs and MDs, and they've just kind of come to a dead end. And then I think you give them a lot of hope and a lot of treatment options. So that's exciting, and we really appreciate that.
Well, thanks for inviting me.
Yeah, you betcha. Thanks everyone for attending, and we'll see you in July. And make sure to hydrate this weekend. It's gonna be a busy one. All right, thanks so much, and we'll talk soon.
Okay.